Hi, in this video I'm going to go over additional questions about neuroinflammation. So one of the questions that has come up is, do I need to learn functional neurology rehabilitation or can I just refer to a practitioner? Well, I think you can absolutely refer to a practitioner, but realize that it doesn't have to be a functional neurology practitioner. So if you do an examination and you do an evaluation, or if you have a person fill out the brain region localization form and you see some areas where a traumatic brain injury has caught up with someone, or there's clear areas that some part of the brain is injured, there are lots of different ways to rehabilitate the brain. You can definitely work with great physical therapists. There's many physical therapists trained in brain rehabilitation. There's also people that are vestibular rehabilitation experts. Those would be great for patients that have cerebellar issues or balance issues. And the world of functional neurology is really, really small. And even within the community of functional neurology, I would say not everyone is competent. So just because someone says they're a functional neurology practitioner, that absolutely does not mean that they are an expert in brain rehabilitation or anything of that such. It's just that they had some training in it. Ultimately, you're going to have to know the practitioner you're working with, build a good relationship, make sure that they can work with your patients and with you. Um, and there's also people that do things like visual therapy. There's some optometrists that do phenomenal work out of the NORA group, NORA, that do brain rehabilitation just with different types of eye movements. And just exercise and movement and all those things are very useful. So I think one of the things that we have to all appreciate is that we can only do so much. And we all have a scope of practice and a license and training to do so many things. Like for myself, as a DC, I can't prescribe medication. I can't take patients off medications. I can't do IV nutrition. So if those things ever arise, I refer them to colleagues, friends, to help manage that case. They have the training expertise in that area, and I don't pretend to do it all. So I think functional neurology is no different. There's times you need to refer out to an expert or specialist to do other types of things that they're trained for, and functional neurology itself is not an easy task, or brain rehabilitation takes it's a career. You can't just go to a weekend seminar or have us just present to you how we do brain rehabilitation with each patient in a weekend. It's much more complicated than that. So I think you have to find your team, and if you are starting to look for patients that have neuroinflammation, and this is something that you may have not done as much in the past, and as you've been exposed to the clinical presentation of a person who has prime glial cells or neuroinflammation, or you're really being more careful looking at traumatic brain injuries, it doesn't hurt to be able to find someone on your team in the area where you practice, in the country that you're in, that can really help with some type of recovery or rehabilitation. And remember, we do have some basic apps to get patients started. If you find things, if you use the brain region localization form and match those things. So I hope that answers that question. Can toxin exposure like chemotherapy result in microglial activation? Yes, absolutely. So any inflammatory response can turn on microglial responses. Now, when you look at toxins, one of the things that toxins do is that they uncouple the mitochondria. So when the mitochondria gets uncoupled and you start to have this oxidative stress response in the mitochondria, that produces free radicals like hydroxy radicals and superoxide anions, and those create an inflammatory cascade then that turns on microglial cells to an inflammatory M1 state. Now, you have to realize that chemicals, majority of chemicals are unable to cross the blood-brain barrier. So the people that are really most sensitive to toxins are the ones that really have breached blood-brain barrier. Now, chemotherapy typically, when it's aggressive, does break down the blood-brain barrier, the gut barrier, the lung barrier, the nasal barrier, creates oxidative stress, and really creates this inflammatory response. The response to chemotherapy is going to be different from one patient to the next, but remember, it really depends on what factors were there before the chemical or exposure to chemotherapy. So if someone already had injured cells in the brain, had glial cells that were already primed, their reaction to chemotherapy or any kind of toxic insult, oxidative stress insult, would be much different than someone who doesn't have that. So that's where it's really important to look at those things. And if you remember one of the slides that we talked about, variables that impact brain injuries, we really focused on, it's not really how hard you hit your head. It depends on how active and how what kind of inflammatory, anti-inflammatory state microglial cells are in. So if they're leaning towards an M1 pathway, with mechanisms such as diabetes, or being a smoker, or having an inflammatory bowel condition, or a pro-inflammatory diet, or being anemic, or having previous brain trauma or vascular inflammation, antioxidant reserve issues, then the traumatic brain injury is going to have a much, much more aggressive inflammatory response upon the exposure, in this case injury. But you could really replace the word injury here with toxic chemical exposure or chemotherapy, and that would really determine the severity of the inflammation. So the second part of this question is, what type of inflammation occurs in the brain with radiation exposure? So it's just oxidative stress as the main mechanism, like we talked about. How much of an issue can this be versus physical trauma? So there's a lot of similarities here. The main difference is that physical trauma itself can actually prime glial cells. Because remember, when there's a traumatic brain injury, axons, the neuron, the axon sheaths shear and tear, and then you get debris and proteins released into the brain, and then these glial cells start to recognize those, and those debris turn on things like heat shock proteins and different chemokine messengers that then actually switch the glial cells into a prime state. And this is when they actually go from that branch-like structure into that macrophage round structure. The anatomy actually changes. That's priming. So it is possible for toxic chemicals to do that, but I'm not aware of chemotherapy actually causing priming. My only understanding of chemotherapy is that it creates an oxidative stress, creates some systemic inflammation throughout the body and into the brain, uncouples mitochondria, leading to this activation of microglia, but it doesn't actually change the anatomy of these microglial cells to a primed state. So I hope that answers the question. Okay, next one. Can brain surgery result in microglial activation like an injury? Absolutely. So any injury to the spinal cord, any injury to the brain, axons are going to be injured, proteins are going to be released from debris of neurons being broken. So there's always some degree of microglial activation from any kind of surgery or injury. And I think it's fair to say that, especially with those that have had brain injury or spinal cord injury, one of the things that they say is that they've never been the same since the surgery. They may have had the surgery give them great benefits for whatever the occur may be. Maybe they had a space-occupying lesion that was infiltrating a tissue and they had to get removed. But they'll notice just the whole clinical presentation of glial priming. They had a spinal cord injury or some kind of brain injury, or surgery, I should say, that certain things can activate those glial cells. So they may notice significant brain fog and pain, or not necessarily pain, but significant brain fog and loss of function if they get exposed to inflammatory triggers ongoing since the date of surgery. So that's just the way injuries work in general. Okay, next question. What strategies can we use to indicate the anti-inflammatory form of prime glial cells after long-term steroid use? Well, I think one of the things to understand about long-term steroid use is that the steroids break down the blood-brain barrier and the gut barrier and the lung barrier and the nasal barrier. And this is one of the major concerns with steroids. Steroids also completely shut down both M1 and M2 pathways. And this is one of the things that we do know about, because when they look at studies where they're trying to reduce the risk of ongoing microglial neuroinflammation, when they use steroids, they get very, very poor results in long term, because in the acute stages of an injury, both the M1 inflammatory pathway to get rid of debris that's caused from the injury and inflammation, and the M2 pathway, which helps protect neurons, are both shut down. And you really need that M2 pathway to recover. So long-term steroid use really shut down the M1 pathway, which would be good, but they also shut down the M2 pathway. And when they shut down the M2 pathway, it's really hard for that brain to recover and to really release growth factors and different types of peptides and messengers to allow neurons to branch into each other and grow. Because remember, the microglia support neurons, and once there's an injury, neurons have to branch around the injury or branch around the area of inflammation, and they can only really do that if they have M2 activity. So steroids break down the blood-brain barrier and have an impact on M2. They may be absolutely necessary in acute stages, but long-term steroid use has this potential to also dampen the M2 pathway. And I don't really think there's any amount of nutraceuticals that can really push that M2 pathway up if there's such a powerful immunosuppressant like steroids being used. But at the end of the day, if they come off the steroids, or you as a clinician can address the underlying inflammatory issues that are leading to steroid use, then it would be a really good idea to go on to that list of nutraceuticals we went over that really can help balance that M1, M2 pathway, things like polyphenols and things like essential fatty acids and short-chain fatty acids. Those are all basically everything we talked about in the neuroinflammation course then could really apply. But remember that when someone is on steroids, especially heavy steroid use, that M2 pathway is also shut down, not just the M1 pathway, and the blood-brain barrier is vulnerable. Okay, next question. Can systemic inflammation cause neurological inflammation? Yes. So that was one of the key things about the course. We went over 4 independent pathways in which the brain can be inflamed with a blood-brain barrier that's intact and functioning normally. So what may these symptoms look like here? Well, basically, remember that with brain inflammation, we have different types of inflammation. Sometimes the neuroinflammation is what we call transient, so it comes and goes. People get the most common example of that as someone gets exposed to a food sensitivity, something like dairy sensitivity or gluten sensitivity, soy, egg, albumin being the most common ones. And then once they get that food protein exposure, they have some brain fog and some slowness in their cognitive activity. So those are all signs that can happen with transient inflammation. Chronic neuroinflammation, what really happens is people really just have chronic depression, no motivation, they need excessive amounts of sleep. It's kind of like a sickness behavior syndrome. And for people that have prime glial cells, they can really completely shut down to where they get to the sickness behavior syndrome where they just don't want to get out of bed, don't want to really do anything at all, need excessive amounts of sleep, have no appetite. So, I think we cover these really well in the program. You just may need to go through the course material a couple times. I actually think most people that take all of the courses that I'm going to develop for the Crosby Institute, I think you really need 3 times through the course. I think the first time you need to go through the course just to get that exposure, and then kind of have you get your thoughts going. And then I think the second time you really need to go through it to kind of fine-tune areas and maybe you missed a few things. And then I would say then it's a really good time to just really implement that material into your practice. And the third time would be after you see some patients. And after you see some patients, you have a completely different perspective as you start to think about neuroinflammation. And then the third time through, after you've been working with the model, I think if you watch the course material, you're going to get a lot more out of it. And then eventually, as you work with patients more and more, let's say you really start implementing a clinical strategy to evaluate and work with patients that have neuroinflammation and glial priming. And I think if you watch that, let's say the 4th time, maybe even a year from now or 2 years from now, then you can really pick up on some of the little clinical things you may have missed because there was such a focus on trying to understand the concepts itself. So this is also why we organize the program, so we do have access to the course material after the course. And we really encourage pre-registration, because with pre-registration we give people access for 3 years versus if you register last minute, we only give 1 year access. So we really encourage people to do early bird registration and get that 3-year course access, and also be able to go through the information over and over again, because it completely has different meanings to you as you process the same information. From when you first learn it to when you review it to when you actually work with patients, and also when you get much more experience working with patients. So, I would suggest those things. Next question: can you discuss what mild cases of microglial priming might present like? So, mild cases of microglial priming are basically just some brain fog, can't focus, can't think, can't concentrate. Those are the main ones. And then remember, we don't really necessarily cause headaches or pain with these. The glial cells just shut down nerve conduction, the speed of neurons. Another key factor that's very common is that when these microglial cells are activated, they create a neuroinflammatory response and uncouples the neuron, mitochondria, the other cell in the brain, and that leads to reduced endurance. So with mild cases of brain inflammation, not only is the speed and efficiency of the brain compromised, which many people call brain fog, but there's also reduced brain endurance. So a person doesn't feel like they can read a book as long, they don't feel like they can drive as long, they get easily tired, they need to take more breaks if they're working, using cognitive tasks. So those are all signs of brain inflammation. If you don't have brain inflammation, you should have lots of brain endurance, and your cognitive speed, your brain process speed should all be working at a high level. So you'll see with subtle brain inflammation that these things start to get compromised. With transient, it comes and goes. With chronic neuroinflammation, it's there all the time. With prime, there's just a significant severe reaction where the brain just doesn't function at all. and the person really needs to stop whatever they're doing because the priming effect creates such an exaggerated inflammatory response. Okay, the second part of this question. Are there specific neurological symptoms we can look for, like headaches, migraines, referred pain, specific body regions, psychological symptoms, mild depression, difficulty getting things done, or focusing, gut symptoms, or pain? So I think I answered some of those questions, but let me also point out a few things. One of the things that I wanted to point out to you in the course was to evaluate the brain without being an expert in neurological evaluation. You can look at the brain region localization form. If you look at the brain region localization form, one of the things that we went over in the course is that if you see a section of symptoms that are happening all the time or frequently, then in one region of the brain, then that's probably an area of the brain that's injured. So when neuroinflammation takes place in the brain, the areas that are already injured or the areas that are already primed is where many of these symptoms may come out. So for example, if someone had a right parietal lobe injury, you would see that in the brain region localization form, and they would tell you that they can't really perceive their leg and arm, the opposite side of their body, and they may have tingling sensations and so forth. So when they get brain inflammation, they may have left or right leg pins and needle sensations, or really heavy or really clumsiness in that side, or they injure themselves and sprain ankles on that side. That could be one presentation of neuroinflammation. And for someone else, they may have some degree of injury or inflammation in their Broca's speech area, maybe in the left frontal area, and you would identify that with the brain region localization form. But when their brain gets inflamed, because of that priming that exists there, their symptoms are going to be maybe that when they speak, they fatigue and they have a hard time producing words, and just the fact of speaking gets them really exhausted. They start slurring their words. So remember, one of the things I was trying to teach in the course was, you have to look for mechanisms of neuroinflammation. Is it transient? Is it chronic? Is it prime glial? Has it turned into autoimmunity? We haven't talked about autoimmunity in this neuroinflammation module, but we're going to get into it in the future module. And then the other key thing is that when you see neuroinflammation, evaluate the brain and see if there's any local areas where there could be some early degeneration, because early degeneration is associated with priming, and then any kind of injury to the brain. And if those are there, those are the symptoms you would expect to find when the inflammatory cascade gets activated. So it could literally be any one of these symptoms. So if you look at headaches, well, headaches and migraines are not typically caused from brain inflammation. However, there are areas of the brain that control autonomics, that control blood vessel flow, because headaches and migraines are really vascular, but autonomic control of vascular systems are dictated by different parts of the brain involved with parasympathetic and sympathetic tone. So if you have dysautonomia from brain injury, then that could be triggered, but it's not a common cause. Referred pain to specific body regions, that's like the example I was giving with the parietal lobe. Psychological symptoms, if there's any injury to the limbic areas, psychological symptoms are possible. Depression is the most common. If they're getting things done or focusing, those are all frontal lobe. Those are executive functions. Gut symptoms or pain, those are also possible. Remember that one of the things we know is that when the brain gets really inflamed and nerve conduction speed goes down, one of the key things about the brain is the brain activates areas of the brainstem, specifically in the periaqueductal gray area. And these periaqueductal gray areas have descending serotonergic pathways that then cause inhibition to the posterior horn, where you have nociceptive input come in. So a lot of times when people have really bad brains, really inflamed brains, they just have chronic pain all the time. And the pain could be in the gut, it could be in a non-localized area, they just don't know, their whole body hurts, or it could be an area of a previous injury. So those are all things that you will see. Okay, next question. For people who do not have significant microglial priming, which is inflammation, can you use intermittent fasting to help? Is there evidence that a 16-8 versus 1 to 2 day per week or fasting is better? How about fasting mimicking diets? Well, you can go into intermittent fasting at any point you want, but the key thing about intermittent fasting is that you're really getting into a state of ketosis. And one of the things we went over is several papers on ketosis, and one of the things we know about ketosis is that ketones produced are not just an alternative fuel source for the brain, but they actually have an anti-inflammatory effect on the brain. So it doesn't really matter if someone has significant priming or just brain inflammation, or someone who just wants to optimize fuel delivery to the brain, or have a or they're trying to just use a ketogenic diet for improved cognitive function, that when you actually get into a state of ketosis, you have efficient fuel delivery, but you have an anti-inflammatory state. So it can be used in any state. Now, whether you do one type of fasting, 16-hour day fasting versus 12-hour, or just fasting for 2 days, that's really up to the individual. As long as they are producing ketones, they're getting the benefits. So some people have a preference to just not eat food for a couple days. Some people have a preference to do a 16-hour fast. But remember, one of the key issues we talked about with fasting was that, you really want to make sure they're efficient in using ketones first. So I really stressed out on the course, just from experience having patients totally fall apart trying to get into ketosis and doing fasting, is I don't really have patients try fasting until they can actually efficiently get into what's called keto adaptation. So we talked about in the diet section of the coursework, where we went into ketogenic diets, of having patients really go into ketosis and then measure that with urinary ketone strips. And after about 2 to 4 weeks, somewhere around that period, they'll stay on that same diet, but they'll no longer show up with ketones in the urine, or they have very, very trace levels. And that means their body's getting used to use ketones and they're no longer spilling over. That's the best time to really have patients go into a fasting diet. If you have someone who's got like significant blood sugar instabilities and they have a roller coaster ride, and you haven't tried to go into a fasting state, it's really a bad idea. They're not going to be able to do it, and if they do it, they're going to be miserable, and they're going to suffer all the way through. They don't have the efficient system to use their body fat reserves for energy. So be aware of that. Fasting mimicking diets, I think what you're referring to is where you're taking exogenous ketones to really think your body is in ketosis. They're not the same thing. Unless your body's actually making ketones, taking exogenous ketones are not going to have an effect. There's some studies there's 2 studies that I know of that were published that show if you do take things like hydroxybutyrate, or even if you take things like short-chain fatty acids, like butyrate itself, it can speed up your body's metabolism to burn ketones. But at the end of the day, you still have to just limit your sugar and carbohydrate intake to get into ketosis. So I would say if it's a fast mimicking diet without actually producing your own ketones, it's not going to have much of an effect. Okay, next question. How long to keep a person on a ketogenic diet? It really depends on your clinical goals. For some people, it's just to get them through recovery. For other people, they're dealing with a neurodegenerative disease, and you're trying to slow down the progression of it. From some people, that they have to eat that way if they have significant cognitive tasks to get their job done. But it can be long term. However, if someone does do a ketogenic diet long term, they really need to also practice breaking out of ketosis and going back in. So if you have someone who's got, for example, a neurodegenerative disease, let's say they have Parkinson's disease or dementia and Alzheimer's, and they're engaging in a ketogenic diet because if they do, they function a lot better, they have more energy, their cognitive function is enhanced, and they really like to stay in that state. But you'll notice with some of them, they'll start to, at some point, get depression, or other times they just get bored. And it's not a bad idea to have them break a ketogenic diet. So if my patients are on a ketogenic diet long term to slow down a neurodegenerative disease, then I would have them typically break out of ketosis maybe every 3 to 4 weeks, have a meal, and then as their ketosis gets more and more efficient over time, they can really go back into it really quickly. So if someone, for example, has been doing ketogenic diet for 6 to 8 months, and their pathways using hormone-sensitive lipase and other enzyme pathways to break down fat into ketones and triglycerides into energy into ketones is really, really efficient, that once they break their ketogenic diet, it doesn't take them 3 days to get back in. They can get back into it within the next day. And so I think it's good to break ketosis, to activate other health metabolic systems, and to get different types of fuel and more diversity in the diet. But that's the key thing. Now, when people do the ketogenic diet, it's really important that they eat lots of different diverse vegetables, and really make sure that they get the gut microbiome diverse source as they follow that if they're doing it long term, and just in general for anyone who's doing it. Okay, So the question is, depend on the severity of the symptoms? No, I really think it depends on the clinical goals. However, if you're really trying to do the most effective and aggressive diet for reducing brain inflammation, it would be ketogenic diet. And then once they get keto adapted, to do ketogenic diet with intermittent fasting. The intermittent fasting can be 12 hours, 14 hours, 16 hours as they get more efficient with it. And it can even be someone who does it for a day or two. But that's really up to the patient. They're all going to have a positive effect. Okay, next question. What would these be different in a child who has born? Okay, so I think the question is, would neuroinflammation be different in a child who was born with C-section from a prime mother? Well, I think one of the things that we have to understand is that this is something that we cover a lot in the gastrointestinal module. And we talk about the microbiome. So we know that the microbiome is forever different for a child who has had a vaginal birth versus C-section. They have different species. People that have had C-sections, they tend to have a higher content of bacteria in their microbiome that's found in the skin versus those that have a vaginal delivery. Then they have different bacteria in their microbiome that is found in the vagina. And then these things have different mechanisms. And there's some research that shows that children that have C-section are more primed to have inflammatory reactions and even allergies and immune sensitivities. So there's some prospective studies that suggest that there's some ongoing differences for just systemic inflammation. Now, whether the mother is primed or not, that doesn't necessarily mean the child will be primed. Primed glial cells means that there's a certain amount of neurons in the cells that have actually changed structure and they're more reactive to inflammation. What really is most important is during the development of the fetus is that the mother doesn't have many inflammatory triggers, especially neuroinflammatory triggers, like their diabetes is controlled. They don't have an inflammatory diet. They have healthy amounts of fats in their diet. All the different variables that are anti-inflammatory. They have diets rich in polyphenols and all the things that we talked about that are crucial from lifestyle to manage neuroinflammation. Okay, next question. Can neuroinflammation occur when someone loses body fat quickly? Yes. So remember that the body fat is really a storage of energy as fat, but the body fat is also an area where there's a storage of toxic compounds and chemicals. So one of the things that happens is that when someone loses body fat very quickly, the chemicals and toxins like bisphenol A and different fat-soluble toxins get released into the bloodstream. And if that load is much faster than the body can biotransform or clear out of the body, then you have these circulating inflammatory or metabolic or toxic chemicals in the body, and they can induce oxidative stress that can cause inflammation in the body. And then some of those, if the blood-brain barrier is reached, they can also cross. That can be a more severe issue. But also from some of the research that I've had the opportunity to publish with Dr. Vijdani is that chemicals can actually bind to proteins, become neoantigens. So if you, for example, lose a lot of body fat and then you get these chemicals released in your bloodstream and your liver can't clear them all at once, then what happens is that these chemicals bind to proteins that's found in circulating blood called albumin, and then albumin changes the structure, becomes a new protein, and that creates an inflammatory reaction. We actually just published a study in the journal Toxins where we actually showed in Parkinson's disease patients that they have established, well, the literature's established that Parkinson's patients have very compromised clearance of bisphenol A. So we showed that bisphenol A, when it can't be cleared, binds to albumin, becomes a new antigen, and we found significant correlation and risk ratios with those that have BPA albumin antibodies with those that have alpha-synuclein antibodies. So we know that that's an issue. So ultimately, if a person loses body fat very quickly, and this can happen if you guys are working with patients and doing ketogenic diets, they can lose body fat very quickly. And if you see significant patterns of neuroinflammation, you definitely want to look at supporting their biotransformation pathways, the liver pathways, things that support sulfation, glucuronidation, methylation, whatever nutraceuticals you use to support phase 1, phase 2 detox could be really, really important for them if that's happening. Okay, next question. And last question. Is there research that lectins cause neuroinflammation? Yes, there is. And there's specific research with wheat germ agglutinin, which is a lectin portion of gluten not associated with the protein portion of gluten. So wheat germ agglutinin, not to be confused with the gluten. Wheat germ agglutinin is the lectin portion of wheat, and that has been shown to directly cross-react with synapsin, which is a key protein in the brain. So we know that there's significant risk with lectins and neuroinflammatory responses. We're actually getting ready to submit a paper for publication where we looked at different types of lectins, whether it was found in pea protein or different types of vegetables and foods, and also wheat germ agglutinin, and to see what kind of risk that provides for those that may or may not have autoimmune antibodies. And there's significant risk for neuroinflammatory autoantibodies when someone has reactions to lectins. Now, not everyone is sensitive to lectins, and lectins aren't bad for everyone. There is a genotype that has this so-called agglutination process that makes them very, very vulnerable to lectins. We're going to go into that in great detail in the autoimmune course. So in that case, I would just say that lectins have been shown to cause some neuroinflammation if there's wheat germ agglutinin reactivity. And the key thing is if the person has reactivity. And then if you have someone who is sensitive to lectins, and obviously if you can cook them, that'd be an ideal scenario. It's really the seeds of foods that cause the reactions, like tomato seeds are where the lectins are. So many times you just get rid of the seeds and cook the food like a tomato and boil them, and then that should be okay. But these are some possible mechanisms. Lectins are a potential inflammatory trigger for some susceptible individuals, but not for everyone. So I hope that answers the question. Anyways, I hope this video helps to clarify some things that have come up during the course, and thank you for your attention.